morning. Thank you so much for joining us today. I'm Mary Ford, the Director of Policy and Research here at the New York Health Foundation. We are really excited today to be discussing how to use data to strengthen primary care in New York. I am also very excited to have several incredible panelists joining me today. This is actually the first of 2 webinars that we'll be hosting with our esteemed partners with the Primary Care Development Corporation, or PCDC. The second event will be held on May 9th, so look out for an invitation to that event. Before we get started today, there are just a few housekeeping items that I will mention. We will be recording this webinar, and a recap with the link to the recording will be shared and circulated afterwards. Video and audio are disabled for attendees, but we invite you to use the chat box throughout the event to share any questions. And after the presentation and discussion, we will be taking as many questions as we have time for. So again, use that throughout the presentation. We also have a closed captioning feature available, and you should be able to find that at the bottom of the screen. So now I will hand it over to Louise Cohen with PCDC to kick us off for the hour.
Hi, good morning. Thank you all for being here. I'm Louise Cohen. I'm the CEO of the Primary Care Development Corporation, and I'd really like to thank the New York Health Foundation, as well as the New York State Legislature and the Department of Health for funding this important work. You know, PCDC has long advocated for a strong primary care-centered healthcare system in New York State and around the country because we know that that is key to keeping people and communities healthy. We also know that what gets measured gets done. And so we realize that there's a gap in information. Until now, there has really been no concise compilation of key facts about New York State's primary care landscape that would enable policymakers, advocates, and practitioners, essentially meaning all of you, to have an actionable snapshot about the state of primary care in New York. Today, we're unveiling PCDC's New York State Primary Care Scorecard, which is a first-of-its-kind resource that presents data on the state of primary care in the state and serves as a baseline for future monitoring. This work follows some other states who have created dashboards to monitor the health of primary care, as well as some national efforts. This scorecard, as you will hear, brings together a wide variety of data sources to create a really important picture of where we're at with primary care. I'd like to thank first Anna Popenchak and Angela Allard, who are the key PCDC staff who put this together, because I think that this is really an important piece of work. So let me turn it over to Anna, who's going to go through the scorecard before you hear the panel.
Thank you, Louise, and good morning, everybody. I'm just going to share my screen so that I can show you our scorecard. Okay, I hope that that has worked and everybody can see. Wonderful. Well, thank you again, Louise, and thank you, New York Health Foundation, for having us today. We are thrilled to be able, and thank you to everybody joining us, because we are thrilled to be able to share the New York State Primary Care Scorecard that we have been working on. In the time that I have this morning, I will present our key takeaways and some of our findings. But before I dive into the findings, I wanted to just add a little bit more context about the inspiration for this work that Louise started to talk about in her opening remarks. Primary care is essential. It saves lives, improves individual and community health, and is a cornerstone of vibrant and thriving communities. The value of primary care has been acknowledged by several landmark reports, but the challenge really remains on how to enact policies and programs that will prioritize investment in primary care. Data are really powerful in making the case for why primary care is important, but how data are presented and packaged can make a difference in how accessible it is and whether or not people feel comfortable utilizing it and understanding it. It is for this reason that scorecards and dashboards have been gaining traction as useful tools for communicating policy-relevant data. In 2023, several organizations published primary care scorecards, highlighting a growing precedent for the need and use of these types of tools, including the Milbank Memorial Fund's The Health of the U.S. Primary Care Scorecard, and then 2 state scorecards for Massachusetts and Virginia. All New Yorkers deserve access to equitable, affordable, and high-quality primary care, which is why PCDC decided to create the first New York State Primary Care Scorecard in order to develop a tool that will support policy, programmatic, and budgetary decision-making by presenting the state of primary care in New York and establishing a baseline to track our progress against in the future. In the interest of time, I won't be going in depth about the methodology, but briefly, this scorecard brings together various publicly available and proprietary data sources, and the data reflect the most recent year of available data. More details on our data sources and data definitions can be found in our technical appendix. Before I present the findings from the scorecard, I'd like to first share our key takeaways. The first is around workforce. As I'll show you in a few slides, there is an insufficient supply of primary care providers across New York, and rural communities are facing an even greater shortage than urban areas. Secondly, across the state, access to primary care varies greatly by geography and population. Not only does access to primary care differ, but in New York State, there are considerable racial and ethnic disparities in health outcomes. Finally, there is an urgent need for publicly available data on primary care expenditures in New York. Currently, New York does not have a publicly available data source like an all-payer claims database for calculating the percentage of the total cost of care spent on primary care. Estimates do exist from other reports and surveys, but they range from 3.4 to 13.8%, depending on the definition of primary care, the data sources used, and the payer. And this underscores that addressing these data gaps is a priority in order to fully understand the state of primary care in New York. And now to our findings. The New York State Primary Care Scorecard is organized into 4 domains. The first is workforce, and these metrics focus on the primary care provider workforce and pipeline. Next is access, which includes measures that capture the ability to access primary care. Third is performance, which includes metrics that assess the performance of the primary care system with regard to access to preventative and chronic care services. And finally, health outcomes, which are metrics related to primary care services that measure the health status of the population. I'll now present key findings from each domain. First, workforce. The data on the next few slides are from 2023 and from IQVIA. For the purpose of this scorecard, the primary care provider supply is defined as physicians, nurse practitioners, and physician assistants who work in an outpatient facility with a specialty of family medicine, general medicine, internal medicine, pediatrics, or geriatrics. We utilized this definition of provider supply to align with measures in other scorecards. However, we do acknowledge the important role that OBGYNs and behavioral health providers play in primary care and present the ratios of these providers in our supplementary data tables. In New York, there are 111.7 primary care providers per 100,000 residents. This varies across counties, with rural counties on average having fewer primary care providers. This map shows the location of primary care providers across New York State. The larger the circle, the higher the number of providers. And as you'll see, primary care providers are concentrated in areas with major cities. Looking closer at the types of primary care providers, there are 77.1 physicians, 28.2 nurse practitioners, and 6.4 physician assistants practicing primary care for 100,000 residents in the state. This results in a distribution of about 70% of the primary care workforce being physicians, 25% being nurse practitioners, and then 6% being physician assistants. One of the goals of our scorecard was that we wanted to disaggregate data wherever possible by county, age, and race and ethnicity. As such, we've also developed maps looking at the location of pediatricians and geriatricians in the state. So the map that you see here, once again, the dots represent the location of providers, in this case, pediatricians, but underneath we show the percent of the population ages 0 to 17, and the darker the color is a higher percentage of children. And we find that rural counties in New York State have less than half the supply of pediatricians than urban counties. We created a similar map for geriatricians, and here the underlay is the percent of the population ages 65 and above, and again, the darker color indicates a higher percentage of older adults. The distribution of geriatricians across New York State may not be adequate to serve the aging population. As you can see in this map, in rural areas, there is a higher proportion of adults over 65. However, most of the geriatricians are concentrated in urban areas, many of which have a lower concentration of older adults. We also looked at the percentage of primary care providers accepting Medicaid. And now in this map, the shaded colors represent Medicaid acceptance rates, which range from 62.7 to 100%. And of note, the percentage of providers accepting Medicaid in upstate counties is slightly higher than in downstate counties. Now turning to our metrics related to access. So the style of graph that you see here is one that we use for several metrics. So I'd like to briefly orient you to what you're saying since it'll be the same for a number of slides. In these figures, the yellow line is always the total or the state value, and then the colors below is the breakdown by race and ethnicity. So our first measure looks at whether individuals avoided care due to cost, because as we know, cost can be a huge barrier in determining whether or not individuals access healthcare. In 2022, 20.5% of Hispanic and Latino residents reported avoiding care due to cost in the past year, 3 times that of white residents. Next, we examined potentially preventable hospitalization rates. Lower preventable hospitalization rates signify better access to preventative services, which in turn reduces unnecessary hospitalizations and healthcare costs. From 2018 to 2020, the potentially preventable hospitalization rate among Black residents was 200.1 per 10,000, which was over 2 times higher than white residents. Another metric often discussed in relation to primary care is preventable emergency department visits. In New York State in 2021, among adults ages 18 to 64 who had an employer-based insurance plan, the rate was 134 per 1,000. And this value was comparable among Medicare beneficiaries at 136.6. So although these data points can't be further disaggregated, we felt that this was an important metric to include in order to establish a baseline. Our hope is that we will see this number decline in the future as people more regularly access primary care and no longer rely on emergency departments for care that could be safely and effectively treated in the primary care setting. For our performance metrics, we aimed to capture measures related to the performance of the primary care system, specifically for preventative and chronic care. First, we looked at adequate prenatal care. And from 2018 to 2020, 1/4 of pregnant women did not receive adequate prenatal care. Black and Hispanic and Latino women had the lowest rates of receiving adequate prenatal care. Childhood vaccinations are a key part of pediatric preventative care, and this map shows the percentage of vaccine coverage among children ages 24 to 35 months in 2022. In the state, only 3/5 of children in this age group had received their early vaccines, but this ranged from 39.3 to 85.1% depending on the county, as you can see in this map. And once again, the darker colors in this map represent a higher percentage of vaccine coverage. For this domain, we also aim to capture some element of chronic disease management and preventative care, and found that in 2021, 21.7% of adults with hypertension reported not taking medicine for high blood pressure control. And then looking at preventative care, the core preventative services metric indicated that more than half of adult residents aged 65 and over are not up to date on core preventative services such as cancer screenings and vaccinations. And finally, our health outcomes domain. These metrics in particular really underscore the racial and ethnic disparities that exist in the state. We looked at avoidable premature mortality, which provides valuable insights into the effectiveness of preventative measures and healthcare interventions to reduce early mortality. And between 2020 and 2021, the avoidable premature mortality among Black residents was 458.5 per 100,000, which was nearly 2 times higher than among white residents. Turning now to 2 maternal health measures, from 2018 to 2020, the percentage of low weight births for babies born to Black mothers was 2 times higher than for white mothers. And this disparity is seen even more in the maternal mortality rate, where between 2017 to 2021, Black mothers had a maternal mortality rate 4 times higher than that of white mothers. Thank you for joining us today, and we hope these findings underscore why primary care is important and how much there is still left to do in New York. Apart from our scorecard, I wanted to highlight the supplementary materials also available on PCDC's website. Our technical appendix, which includes detailed methodology and data source information, as well as the years of data reflected and our data definitions, and then also our supplementary data tables. With a scorecard, you have to find the balance between including as much information as possible, but also keeping it as concise as possible. And so we knew we wouldn't be able to include everything we wanted, but it was a priority of ours to make sure that data were disaggregated wherever possible, especially by county, so that we could make sure that advocates, policymakers, and providers have the data that they need for their communities. So we put everything that we could in these tables, and these supplementary data tables include all the data that were presented today and that are presented in the scorecard, as well as additional values disaggregated wherever possible. If you have questions or comments, please reach out to us. We'd love to hear them, and we'd also are looking forward to hearing how you may use this scorecard in your own work. And I'd also just like to take the time to thank the research and evaluation team at PCDC for their monumental effort to make this scorecard possible. And now with that, I'm very happy to turn it over to Mary, who will introduce our wonderful panelists.
Thank you so much, Anna. That was a really, really helpful overview of the scorecard and all of the important information encased in the scorecard and presented there. I think it's a really wonderful and very nice visualization of all of these data. And I would just really emphasize that many of the folks I saw in the chat had a lot of more specific questions about the data. And I know that Anna and the team at PCDC really have a wealth of knowledge on all of those technical questions that were asked in the chat. So definitely reach out to them. I know they have the answers to all of those questions about the definitions and methodology there for those, so can certainly get those answered. I think one of the things that really sticks out to me is just how much these data help to underpin the importance of the primary care workforce and access to primary care across the state. We know that primary care nationally and at the state level is underfunded, and including in underfunding primary care, that really also includes underfunding research in primary care. So the scorecard really helps fill an important gap in understanding how New Yorkers are or are not able to get care when and where they need it. So I think that's really something that the scorecard helps us better understand. And so joining us today, we have 2 incredible panelists that I'm going to introduce briefly before we dive in. First, I will introduce Natalia Martins, who is the Vice President of Programs at Massachusetts Health Quality Partners, or MHQP. As Vice President of Programs, Natalia works closely with MHQP staff, external work group members, and MHQP board to design projects, operationalize strategic initiatives, and oversee the management of measurement projects that broaden MHQP's impact. And in collaboration with the Center's Health Information and Analysis, Natalia leads the team that publishes an annual primary care dashboard. I have a suspicion that is what we will be talking a lot about. And Natalia received a bachelor's in science and health exercise science from Skidmore College and a master's in public health from Simmons University. We are also joined by Kimberly Joy Smith, who uses she, her pronouns. She is the Senior Director of Public Policy and Advocacy at Callan Lord Community Health Center. If y'all are not familiar with that organization, it's located right here in New York City. Kimberly has dedicated her diverse 25-year plus career to improving health and promoting health equity and social justice for BIPOC, queer, LGBT, and low-income communities. She brings a background as a journalist, nonprofit grant writer, policy advocate, and is a graduate of New York University's Robert F. Wagner Graduate School of Public Service. So I could not be more grateful to have both Natalia and Kimberly joining us today for a discussion. The first question that I'd love to discuss today is for Kimberly. And really drawing on your deep experience in community work, we're hoping that you could help bring some life to some of these data. And maybe talk a little bit about what metrics from the scorecard are you seeing play out day to day at Callan Lord?
Sure. Thank you very much, Mary, and thank you to PCDC for inviting me this morning. So again, I'm Kimberly, she, her pronouns. I'm with Callan Lord. I didn't get a chance to talk a little bit about Callan Lord, so I'm just going to do that quickly here. We are a federally qualified healthcare center based here in New York City. We have 3 clinic locations in the South Bronx, our flagship clinic in Chelsea, and our newest site in downtown Brooklyn. We also have 2 satellite clinics that provide behavioral health services. We serve about 20,000 patients a year with 147,000 visits. And we are unique as an FQHC, perhaps because we are not solely geographically focused. Our patients come from many zip codes across New York City and beyond, because we provide high quality, affirming, non-judgmental primary care and related services, mostly to the LGBTQ plus community, though obviously we are open to all regardless of ability to pay. So I come to primary care from a long career and history with HIV and AIDS, as well as LGBTQ plus health, public policy, and advocacy. So my lens, and I'm very excited about the scorecard, but is really to be able to use data to be able to tell stories, to describe and enumerate a problem and make the case that will help shape policy interventions, create change, and advance health equity. So in terms of how the metrics from the scorecard play out day to day at Callan Lord, I mean, I think much of these broadly rendered categories and metrics in the scorecard are playing out, whether it's workforce issues, access, performance, or health outcomes. And I would imagine that they play out day to day for other primary care clinics in New York. But at the clinic level, these are going to look a little differently according to your population and perhaps your geography. So again, I'm coming from the perspective from an FQHC. We're situated within areas and populations that have limited medical resources, but offer this affordable care, emphasizing preventive services and delivering culturally sensitive care. So we represent somewhat of a unique perspective in terms of the population that we serve, but of course, the core of what we do is very much centered in the FQHC framework. So one thing that jumped out for me is the access bucket and avoiding care due to cost. This scorecard suggests that people of color avoid care due to cost at higher rates than white individuals. And so this was striking. And of course, LGBTQ plus people are more likely to have lower incomes, leading to postponed or avoided medical care that can affect health outcomes. And Callan Lord exists because of that. And so our patients often have avoided that care and find us to be able to find a safe space. We know that out of the more than 1 in 3 LGBTQ plus adults who postponed or avoided medical care due to cost issues, more than half were transgender or non-binary, and this is across the country. It's not New York State specific. And so it just really makes the case that health centers need to be equipped to care for their geographic or other populations that are specific to their communities. I think in terms of access, we are able to provide care regardless of ability to pay. We do that through sliding scales And if folks are not able to pay, we are able to provide that care regardless. And so I think anything that we can do to expand access to community health clinic is going to, support patient care. And I think that's kind of one area that is playing out on a day-to-day basis for us here at CalNord.
Thank you so much for sharing those perspectives. I think they're really instrumental in understanding kind of the connection of bringing life, as I kind of said at the beginning, to some of the numbers that can seem a little bit abstract sometimes when we talk about them on a presentation slide. And my next question is for you, Natalia. Given your experience with the Massachusetts primary care dashboard, which was some of the inspiration for PCDC's scorecard, of course, and has been in existence for several years now. Do you have some concrete instances of the dashboard being used by policymakers or advocates to advance or make the case for change or action around primary care in your state?
Thanks, Mary, and thanks so much for having me on this important panel discussion. It's a really great question. And before I directly answer it, I want to start by sharing a little bit of background about MHP's role in quality measurement space in Massachusetts. So we've actually been publicly reporting statewide patient experience results in primary care since 2006, and we recognized that primary care was in crisis years ago. So actually back in 2018, we held a roundtable on the topic of affordability and identified access as a key barrier that prevents patients from getting high quality, affordable health care. We did actually recently release data from our statewide commercial patient experience survey that revealed that access to primary care has been declining year to year, and it still hasn't returned to pre-pandemic levels. And I think it's also important to note that our survey captures data from patients who have actually had a PCP visit in the last 6 months. So the decline in access that we're capturing is likely understated. So again, going back to 2018, we were really aware of this looming access issue. And then, of course, as we all know, the COVID pandemic hit, and that left already vulnerable primary care practices at even more risk. So we like to say, as we went to measuring the quality of primary care to the health of primary care. But when we went to gauge the health of primary care in the state, there was really nowhere to go. So we were really lucky to have a great partner in CHIA, the Center for Health Information Analysis. And we launched the first iteration of our primary care dashboard in Massachusetts in January of 2023. And in response to proposed legislation to increase primary care and behavioral health spend by 30%, CHIA started to collect that spend data. But we felt it was really important to get a holistic full picture of what's going on in primary care in order for that data to really resonate. So our dashboard covers 4 domains: finance, performance, which breaks down metrics into access and quality measures; capacity, so thinking about the workforce and pipeline; and also some of those metrics under our equity domain, stratified by race, ethnicity. In our next cycle, which we're planning on launching in May, we'll have additional stratifications. So through those domains, it becomes very, very clear that there's insufficient funding, there's growing workforce shortages, and of course, declining access. So observing those trends, the dashboard, we feel like, serves as a really powerful tool for ongoing monitoring and evaluation. But of course, tracking on its own is not sufficient. We really need people to pay attention to these data. So getting back to your original question, I'll say that the release of the dashboard did garner significant media coverage. There have been several articles in prominent outlets like the Boston Globe and WBUR here in Massachusetts. And also, really importantly, there was a very strong and swift reader response to these articles. The data around access really resonated. And I think, just to piggyback on what Kimberly was saying, kind of bringing stories to these data is so critical. And just in the last month, there have been 3 stories published in the Boston Globe and WBUR about this critical issue of primary care access in Massachusetts. And those articles cite both MHP's patient experience survey data as well as data from the dashboard. And I'll try to chat in those articles if I remember at the end of my spiel here. So, I'm really hopeful that this attention will amplify awareness of primary care issues and potentially influence public perception of these issues, which then, again, hopefully in turn would foster support for policy changes. I will note that a bill introduced this session by Senator Sidney Friedman here in Massachusetts. It's called an Act Relative to Primary Care for You, proposes to reform how primary care practices are paid and hopefully drive improved and equitable health outcomes, reduce ED use and hospitalizations. And that legislation would double the percentage the state spends on primary care over the course of 3 years, from currently where it's at about 6 to 8% to 12 to 15%, while also shifting the way the state administers primary care. So just closing up my thoughts here again, these data serve as a really powerful tool to track the health of our primary care system. They allow us to monitor progress over time and also allow us to pinpoint adjust strategies as we need to ultimately improve the health of primary care. And I probably said this 3 times over the course of talking here, but again, tracking on its own is not sufficient. We need to pay attention. So I'll leave you all with that thought, but thank you.
Thanks so much, Natalia. Those are all fantastic points. And I think that's a great segue to Anna. So really building off the experience of Natalia and other states that do have scorecards and kind of experiences like this with these tools. How do you hope that the scorecard will be used to advance primary care here in New York State?
Thanks, Mary, and thanks, Natalia and Kimberly, for your really important perspectives that you're adding to this panel today. I think Natalia said it perfectly in her remarks. We want this to amplify awareness of primary care. First and foremost, we hope that this scorecard will be used to advance primary care by increasing awareness and knowledge about why primary care is an important issue. Many of us in this Zoom know that the evidence shows that communities with robust access to primary care have better health outcomes, and that primary care is the foundation of thriving communities. And we want everyone to know that, especially those who can increase investment in primary care. And so if this scorecard can be used to elevate the importance of primary care by being something that you can bring along to your meetings or send to your contacts, and inspire discussions around why investing in primary care is important for the state, then that will be a huge win. And apart from that big picture goal, we also hope that this scorecard can advance primary care by just being a resource that people can rely on. As I said earlier, I really think data can be really powerful in making the case for policy change. And we want to put data in the hands of stakeholders to help them make the case for why primary care matters. We spent a lot of time thinking about the design of this product, and we wanted something concise, visually appealing, accessible, and adaptable. So that's why that first page is all key takeaways. So if you have a short amount of time, you can just print that first page and hand it to someone. Or you can focus on a specific domain if that is more relevant to your work. Our goal is really not for this tool to sit on a shelf, but for it to be utilized and cited by advocates and policymakers and providers. And we really hope that the data that informed this scorecard can be regularly used to make the case for why we need to invest in primary care.
Great, thank you. So this is going to be a question, I think, really for everyone, and maybe everyone will have a little bit of a different perspective on this. But one of the limitations I know we often face as researchers, I think really in every field, and certainly not untrue in the primary care research field, is that we don't always have the exact data that we want to answer the exact research question at hand. So we often kind of rely on proxy measures. And one of the things that I really see as a great value of the scorecard is that you cover a lot of ground with a lot of measures available. But I have a maybe sneaking suspicion, particularly as we're talking about the primary care spend and investment, that there are some data points. You already have kind of hinted at some of them. Some data points that we don't have available that may strengthen the arguments that we are trying to make or hoping to make about primary care in New York. So I'm hoping that we might be able to talk a little bit, maybe for the next bit about what are some of the data that are missing in primary care in the conversation that would really help further and strengthen the argument and spur further action in New York. So maybe Kimberly, we could start with you and then kind of talk through that question.
Sure. Well, one thing I was thinking, I know the scorecard covers physicians and supply sort of shortages, and I wondered if there might be an opportunity for even more information and data about provider supply, particularly as it relates to providers leaving primary care or leaving clinics. I do think there are surveys that exist that might capture some of that in terms of what percentage of FQHCs have lost parts of their workforce, largely probably due to COVID, but maybe other concerns. And so I think that would be helpful in terms of continuing to make the case that there's a shortage of primary care and shortage of providers. And then the other thing too is just to get maybe data. I also think this exists about the cost of care and just the gap in between what it costs to provide care for patients and what primary care providers, institutions are reimbursed for that care, either in the public arena or in the private. So those are the two things that I would say.
Yep, absolutely. So maybe Natalia, what about you? What are some kind of perspectives that you might have on data that would be helpful to further build the case for primary care?
Yeah, so I can share kind of the process that we've used in Massachusetts throughout the course of the dashboard project. Is that we've been bringing together a primary care advisory group of providers, health plan representatives, patients, and other experts in the field to help us vet our proposed metrics and weigh in on data gaps. So what we've heard from folks is that we do need better data around access and wait times specifically. As I mentioned earlier, several of our access metrics reflect info from patients who've had a PCP visit in the last 6 months. We also, given the limited supply, we're also hearing about how overburdened PCPs are. So we're going to need more metrics around. I'm trying to think how to frame it. It's like the provider experience or workforce wellness metrics. That's another gap that we've been told we need to focus on. And lastly, in terms of potentially a new domain of data, perhaps it's clear, I think, to everyone that the primary care landscape is changing before eyes. So, metrics to better understand the market, the primary care market, for example, practice ownership and new entrances and approaches to primary care, that will be really critical moving forward outside of that kind of historical brick and mortar setting. How is this impacting quality? How is this impacting access? But the first step is really to see what's out there and get a feel of the landscape.
And how about you, Anna? Kind of round us out on that question about if you could kind of have any other data points, what would they be and how could they be useful to this conversation?
Absolutely. Well, I think while our scorecard is a great summary of primary care in New York, one of the limitations is that we don't have any data on primary care spending. And so for me, a big data gap is we need expenditure data. This type of data is very tangible, and it's a specific metric that shows how much is being spent on primary care. Nationally, primary care accounts for approximately 35% of all healthcare visits each year, yet only about 5 to 7% of all healthcare expenditures are for primary care. And so this lack of investment is a core problem. And so if we could really articulate what is happening in New York when it comes to primary care spending, and have a publicly available data source like an all-payer claims database, this would allow us to calculate the percent of total care spending that is on primary care services and give us a benchmark to be working from. Apart from expenditure data, I also always think that we need to have data that we can disaggregate as much as possible. State values can really mask what is happening at the community level. And so while we tried to disaggregate data as much as possible, we could do better. And so especially being able to disaggregate data that's both by county and then also by race and ethnicity would also be able to give us a little bit more understanding of what's happening in different counties. And that would really strengthen our understanding of disparities that exist within the state and where we need to be prioritizing our resources.
All right, fantastic. Well, we have so many audience questions and keep those coming. These are fantastic. I'm actually going to switch to taking a few questions right now for our panelists from the audience. And the first one will also be for you, Anna. Sorry, you were just speaking. It's kind of a two-part question, but it was first one question that was about whether most states or regions, to your knowledge, whether those have kind of scorecard data availability, since I know you probably have some knowledge of that. I have a suspicion you probably did sort of a landscape scan of those before you embarked on this endeavor. And then the second half of this question is an audience question asking what is being done to really maximize the impact of the scorecard on policy, payment, and public awareness. So I think kind of the dissemination aspect of this work.
Yes, thank you for those questions, and thanks for all the questions in the chat. It's really exciting to see. In terms of what other scorecards exist, well, we're very lucky to have Natalia here with us today to be able to speak about the Massachusetts dashboard. We were able to speak with Natalia when we were in the conceptualization phase of our scorecard, and the other state scorecard that currently exists is from Virginia, and that was also released last year. Now I believe that there are 3 state primary care scorecards, but from my understanding, some other states are also working on them. In terms of regional scorecards, we didn't find any regional scorecards in our review. However, there is the Milbank Memorial Fund's national U.S. Scorecard, which does provide some state level data for certain states. And then also the Commonwealth Fund's Health Systems Scorecard too also has some relevant primary care data that is available. In terms of our dissemination plan, we really hope to make this an impactful product that will have a far reach. We are obviously doing our launch event today, but this is only the beginning of our work in terms of spreading awareness about this product and getting it into the hands of people who can use it. We have a wonderful policy team at PCDC who I know are very excited that this scorecard is out so that they can start using it in their work, and we'll be looking for media opportunities to be able to promote the scorecard, and also we'll be looking at other dissemination efforts that we can do throughout the rest of this calendar year and hopefully beyond. I like to think of dissemination as not just one event, but kind of like a slow and persistent trickle so that we can really keep the messages going and be able to permeate the conversation.
Thanks, Anne. I think that's a really important point about continuing the drumbeat and the kind of ongoing nature of dissemination efforts, definitely. So Kimberly, we've got a really great question of you that's really talking about both the unmet need, but I'm actually going to really, I don't know if you saw the question specifically in the chat, but really talking about strategies used at Cal and Lord to kind of bring patients and individuals into the fold to their involvement in preventive care I would say the question is really asking about bringing them towards being more involved in their care to help with this kind of question about avoided care and barriers of access, and if there have been maybe effective strategies that you've seen.
Yes. So first of all, there are some good surveys and data that has been collected that do sort of track unmet need in the LGBTQ population. I'm not aware of any that are specifically focused on primary care, but often focus more on health and human services writ large. So that does exist. And then the second part of the question is, with the strategies vary by population, depending on who we're dealing with. But one example is that we looked at our internal clinical data, and learned that our transgender women of color were experiencing a disparity in terms of being able to stay virally suppressed if they're HIV positive in comparison to the rest of our patient population. So, you know, when we are able to kind of really take a granular approach and look at data, and we are able to then design strategies. And in this case, we put together a comprehensive care coordination program, as well as an incentive program to offer to transgender women of color who are HIV positive to be able to be virally, stay virally suppressed. And that has been very successful. And in fact, those folks are actually faring better in some of the other outcomes like diabetes control, because they are coming into the clinic and interfacing with our providers more often. And so they are faring better on other measures. So it really does depend on the community or the population in terms of how we might, organize or put together a program that would reach them. We do attract patients, for our sexual health services and are able to kind of get them into primary care. Same goes for behavioral health. You must be a patient of Callen-Lorde to access our behavioral health services. But sometimes it's just a matter of attracting patients for one form of care and being able to sort of flip that switch to be able to reach them in other ways.
Great. I think that's really kind of interesting and important insight to kind of think through and hear from you about how you and Callen-Lorde kind of think about addressing and kind of responding to these questions again that are things that we are seeing play out in these data. Another question that we got from the audience, Anna. And I think kind of interesting towards one of the questions is we have often considered that New York State boasts a higher per capita supply of primary care physicians than many of the other states. How do we reconcile this with the conclusion that there's an insufficient supply of primary care providers across New York State?
Thanks for that really thoughtful question. I think the answer to this really stems from the fact that primary care is underinvested in the United States across the board. And so even though New York may boast a higher percentage of primary care providers, it's likely still not enough. The most recent update from the Milbank Memorial Fund scorecard really focused on workforce shortages, on underpinning this idea that we need more primary care providers. And also going back to the New York example, when we look at the ratios, especially disaggregated by county, we also see a lot of those disparities there. So while the overall number of primary care providers in the state may look like it is sufficient, when you really dive deeper into what's happening within different counties, it can really tell a very different story.
Thanks, Anna. And I see a comment in the chat about considering it sort of a maldistribution. I would say maybe this kind of idea of an inequitable distribution of physicians, especially in rural and inner city, low income communities of color. When you kind of drill down onto the distribution of physicians and providers across the state, it certainly paints a very inequitable picture based, I think, on almost all findings. My next question is for Natalia, and I think may have some really interesting insight again because of your much longer experience with the dashboard in Massachusetts. Is if you had a few minutes to talk about any thoughts you might have about evaluating this work. PCDC is kind of at a more, of course, PCDC has been doing work around researching and research work around primary care access for many years, but the scorecard is a new product. How do you kind of evaluate this work? How would you suggest maybe evaluating success in this endeavor? How have you thought about evaluating success in your endeavor where would you suggest maybe thinking about being in a year from now, 5 years from now?
It's a great question. Yeah. Well, ultimately, as I've mentioned, this tracking would lead to action. So ultimately, in terms of the improvements in the health of primary care, we would see that reflected in the spend data, right? But in the meantime, I think you said the next year, 5 years, we need to consider the current access crisis and workforce challenges, and think about the innovative solutions that might be needed to address these issues. Right now, I believe the national scorecard shared that since 2017, only 0.3% of federal research funding is being directed to primary care. So in terms of quantifying our successes, again, more research dollars, innovative solutions, see that reflected in the spend data ultimately, and see our metrics improve on the dashboard.
Can I maybe ask the same question? Kimberly, I know we kind of talked a little bit before the webinar about sort of evaluating success in this type of work. Do you have any other thoughts about what this type of work might look like from your perspective, if you had to kind of think about what success might look like?
I guess that my success would look like attaching this scorecard to a set of concrete policy objectives. I mean, some have already been mentioned in the chat here, whether it's particular pieces of legislation or funding for this, that, or the other. So I think it would be a great success to see the scorecard with have a complementary piece of material, I guess, that really lays out an action plan at the policy level. And then, of course, if those things get done, that's even better.
Great, and Anna, I kind of have a similar question for you. Somebody had, one of our attendees had asked in the chat about the impending 1115 waiver. I'm not sure if you're maybe fully prepared to kind of talk about that, but in the absence maybe of kind of weaving in the 1115 waiver and kind of the many opportunities I think that are kind of baked in there around the primary care landscape currently, because I think there are many opportunities. This is certainly a time that's ripe in New York State for opportunities at the federal and state level for primary care, either kind of with or without maybe the 1115 waiver. Do you have a vision for some of the data and dashboard modifications based on integration with potentially other data or outcomes, potentially in collaboration with other community-based organizations and data that may be coming out of endeavors like the 1115 waiver? Could you just talk a little bit about kind of what's next?
Absolutely. Yeah, we're very thrilled to have the scorecard out today because we've been working hard on it and we want people to be able to use it, but it also is exciting because now it means that we can embark on the next iteration of this work. Our hope is that around this time next year, we will be able to be sharing an online dashboard that we had a short amount of time to get this scorecard done. And so we really focused on creating a product that could be usable right away. But in the future, we have hopes and plans to develop an online dashboard, which would include all of the data that's in our supplementary data tables and create an interactive tool that people would be able to explore and manipulate and play around with the data in the way that would make more sense for the questions that they are trying to answer. So that's one future iteration of the work that we hope will create, will mean that this scorecard is a little bit more nimble and adaptable to different policies or different changes that are happening in the landscape. I also think, the purpose of this scorecard at this time was to establish a baseline so that we could measure future progress against. And some of these measures are going to be easier to track over time or show change faster than other measures. And so being aware of the policy landscape and any changes that are happening in New York will be key in order to ensure that the measures still make sense for what type of progress we're trying to be capturing and looking at. But our hope is really that this scorecard we can use, as Natalia was mentioning, as a way to evaluate the success of the success of trying to improve primary care in the state by looking at trends over time in the future, so that we can assess whether changes are happening, if they're happening in the right direction or the wrong direction, and whether or not there have been any changes seen from new policies or programs.
Thank you both so much. I'm very cognizant of the time, and I'm afraid that I think we just do not have time to get to all of the remaining questions that we do have in the chat. So as a quick reminder, I just want to let everybody know that we do have part 2 of this webinar series occurring on May 9th. So everybody keep an eye on their inbox for an event invitation for that. It will be a little bit more policy focused on policy opportunities in New York that will strengthen primary care. And also the event invitation is in the chat right now. So you won't just have to look in your email. That will build off of the data, really data being kind of the foundation and kind of platform that help us build the case in many instances for policy. So we hope that you'll be able to join us in just 2 weeks for that discussion. We could not be more grateful to have had Natalia, her deep experience with the dashboard in Massachusetts, and really inspiration for a lot of the work that PCDC did. So having her just insights and experiences were so helpful to hear today. And Kimberly also could not have been more interesting and insightful to hear your experience with Callan Lord, which is just an incredible organization. If you don't know about them, definitely look them up and learn more about the extraordinary history of the organization and work and communities that they are serving in New York. And Anna, again, thank you, and PCDC for all of the thought, research, sweat, maybe some tears that went into the scorecard over the last couple of months. It's a great piece of work, and I know will definitely spur a lot of change and action, and certainly has helped spur a lot of conversation with you all today. Thank you so much for all of the questions that you all had. I know, again, there were a lot of really technical questions that PCDC and the research team can absolutely answer for you. So certainly reach out to Anna and her team. Anything related to definitions, methodology, data sources, they know it all. So we'll be more than able to talk through all of that with you. So with that, I hope we can continue the conversation soon, and really appreciate you all for being with us today. Thanks again.